in our wards, in our hospitals, and whenever we give rounds with our SARS. This is the first ECG that we tend to learn. And as long as we give any exams, be it the FCPS preliminary part, or the FCPS, or the MBBS OSPE, even the MD phase A, or even for me, who I'm a cardiology student, this will be the topic that we will encounter all our lives. And this is atrial fibrillation. So let's start what it actually is. So atrial fibrillation is the most sustained cardiac arrhythmia with an overall prevalence of 0.5% in the adult population of the UK. The prevalence rises with the age, affecting 1% of those aged 60 to 64 years, increasing to 9% of those aged over 80 years. It is associated with significant morbidity and a twofold increase in mortality. This is mainly because of its association with an underlying heart disease, but also because of its association with systemic embolism and stroke. So I would like to add that the content that I have presented today, it's mostly from Davidson, and for a guideline, I have followed the ESC guideline, or the European Society of Cardiology guidelines and their managements, because I found that those are easier to follow than in Davidson. That's why I added a few slides. I will tell you which are those ones. So this is a slide from the ESC. So what is the global prevalence of AF? So as you can see in these continents, it's a lot more than the African continents. And the lifetime risk is at least 1 in 3 individuals with an index age of 55 years. And also AF is more common in males. This is the epidemiology at a glance. So what is actually atrial fibrillation, right? So atrial fibrillation is a complex arrhythmia. This is actually a supraventricular tachyarrhythmia, we can call it, but it is not always a tachyarrhythmia. That's why we can just call it it's a complex arrhythmia, where the atria beats rapidly and chaotically, but in an uncoordinated and ineffective manner. All these words are important. That the atria is the problem, right? Because this is called atrial fibrillation. The atria can beat rapidly. It beats rapidly, but in a very ineffective manner. So the ventricles are activated irregularly at a rate determined by the conduction through the AV node. We know that the AV node passes the conduction from the atria to the ventricle, and it produces the characteristic irregular pulse. The atria usually fires the impulses at the rate of 300 to at least even 600 beats per minute, but the ventricle responds at irregular intervals, and usually the rate is between 100 and 140. Many of the atrial impulses reach the AV node in the refractory period, so not all the impulses are conducted. So atria যতই beat করুক না কেন সব কিন্তু ventricle conduct হতে পারে না. So why is it, what is the pathogenesis? Why is this happening? So atrial fibrillation is caused by both autonomic firing and the presence of multiple interacting re-entry circuits looping around the atria. So two things. One is the atria beats on its own. There are multiple sites of abnormal automatic firing, and these firings create a loop, re-entry circuiting loops. So these episodes are initiated by rapid bursts of ectopic beats arising from the conducting tissue in the pulmonary veins or from the diseased atrial tissue. The diseased atrial tissue can occur due to any condition that causes the rise in atrial pressure. That may be atrial enlargement, atrial fibrosis, or any inflammation or infiltration of the atria. These episodes, re-entry is more likely to occur in the atria that are enlarged, or in which conduction is slow, as is many case in forms of heart disease. This means that the abnormal firing that happens, it can cause a re-entry circuit, but it mostly occurs when the atria is enlarged. So this is the picture from Davidson. So what it shows that number one, that means this is an ectopic beat, right? So the normal pacemakers and the normal impulse should start from here, the SA node. But here we can see that there is an ectopic beat rising from the, this is the left atria, right? The ectopic beat rising from the left atria, mostly from the pulmonary veins. So this is the one that causes the automatic firing, which is ineffective, right? And as automatic firing, and also this is abnormal. And these firings, they may cause a re-entry circuit. So there is loop of re-entry circuits, and this may occur in both the atria. So mainly we can learn that this occurs in the left atrium and the pulmonary veins. So this is a normal conduction. So SA from the SA node to the AV node and how it passes through the bundle of Hayes and the Purkinje fibers to the ventricles. But here, the SA node is fine, but the atrias, they are creating disorganized electrical signals, and this all the signals are not be able to pass through the ventricles. So that's why the ventricles beat at an irregular pace. So how do we classify atrial fibrillation? So mainly three types. One is paroxysmal, persistent, and permanent. So paroxysmal, we know the name paroxysmal, it means the intermittent episodes, and these self-terminate within 7 days. And persistent episodes, these are prolonged episodes, and they usually need to be terminated by electrical or pharmacological cardioversion. We will get to what this electrical and pharmacological cardioversion means in a bit. And the last one is permanent. Permanent means the sinus rhythm cannot be restored without any form of cardioversion. Unfortunately, for many patients, the paroxysmal or the persistent atrial fibrillation becomes permanent, as the underlying disease that is actually causing the atrial fibrillation becomes permanent. This is particularly partly because the electrophysiological changes that occur in the atria tend to maintain the fibrillation through a process called electrical remodeling. So what are the causes of atrial fibrillation? This is the most common question that is asked regarding atrial fibrillation, that what are the causes? Why is this happening? This occurs, this question is asked during the OSPE, this question is asked during the ward rounds, and this is every time we should know why. So the first cause, according to Davidson, is the coronary artery disease, which includes the acute myocardial infarction. Acute myocardial infarction causes a lot of complications, and one of the immediate complications are various types of arrhythmias, which include the atrial fibrillation. Valvular heart disease, especially rheumatic mitral valve disease, that means mitral stenosis. So these two are the most common causes, and there are mainly 5 causes of atrial fibrillation. Okay, so the 1 and 2, and the next is hypertension, and fourth is idiopathic or lone atrial fibrillation. I'll talk more about what is lone in a bit. And the fifth one is hyperthyroidism. These 5 we have to remember. First one, coronary heart disease, including acute myocardial infarction, valvular heart disease, especially rheumatic valve disease or mitral stenosis, and then hypertension, idiopathic, and hyperthyroidism. These 5 are the main causes. So let's look at the other causes. Sinoatrial disease, alcohol. So that means that alcoholic binge sessions can cause atrial fibrillation. Cardiomyopathy, and also includes myocarditis, even pericarditis as well. Congenital heart disease, which may include the atrial septal defect, chest infections such as pneumonia, pulmonary embolism, and as I mentioned, pericardial disease. So the last one, what is lone atrial fibrillation? So lone atrial fibrillation means atrial fibrillation without any cause, as it says, idiopathic. And there is a type of genetic predisposition that may be responsible. 50% of patients with paroxysmal atrial fibrillation and 20% with persistent or permanent AF have no cause and the heart is normal. That means in cases of paroxysmal AF, 50%, and in case of persistent or permanent AF, 20%. These people have no underlying causes and the heart is structurally normal. So this is called lone atrial fibrillation. So that's a lot of percentage. That's why I mentioned it in the top 5 causes of AF. And this usually occurs below the age of 60 years old. So one other question that may be asked in the exams is, what are the causes of AF in young patients and what are the causes of AF in elderly patients? So as we can see, the coronary artery disease, this is less likely in case of young patients, right? So the first cause of atrial fibrillation in young patients is the chronic rheumatic heart disease, mostly MS. And also thyrotoxicosis, this can occur, and the congenital heart diseases such as ASD or any pneumonia, pericardial disease, this. So the first one is MS. MS is the first cause, is the most important cause in young patients. And for elderly patients, this one is the first cause. This is the coronary artery disease, which includes the acute myocardial infarction and hypertension. Because primary hypertension usually occurs in elderly patients, right? So these two are the most common causes in elderly patients. And loan, as I said, the loan usually occurs in less than 60 years of age. So these three are most important in cases of elderly patients, and the MS and the hyperthyroidism is important in younger patients. So how do we take a history when a patient comes with atrial fibrillation? How do we take the history? So we usually want to know why this atrial fibrillation is occurring. So that's why we would take the history. If he or she has a history of rheumatic fever, that means we want to find if she has mitral valvular disease, or an older patient. We want to ask about the ischemic heart disease, any history of thyrotoxicosis, any recent intake of alcohol, any known history of hypertension. That will include how long he has the hypertension and what medication is he taking, and if it is controlled or not. Any acute chest infections, as I said, pneumonia can cause AF. Any recent surgeries, some surgeries such as valvular surgeries can cause atrial fibrillation. That's why we need to know about this. And also CABG, that means coronary artery bypass grafting, that may lead to atrial fibrillation. So how does the patient present to us? So this I took from the ESC guideline. So the clinical presentation, the patient might just be asymptomatic or silent. We might just feel the pulse of the patient and feel that there is an irregular pulse. And that's how we come to know that, okay, the patient has AF. So the patient might just be asymptomatic or silent. And if symptomatic, these three are the most common features that the patient comes with. The one is palpitations, dyspnea or shortness of breath, and fatigue. And this may also cause chest tightness or pain, poor effort tolerance, dizziness, even syncope and disordered sleep. Sometimes the symptomatic patients become hemodynamically unstable. We need to know this because we're going to talk about this later in the management section. So what does hemodynamically unstable mean? If the patient comes with syncope, that means transient loss of consciousness. If the patient comes in symptomatic hypertension, this is very important. That means if the patient comes with systolic blood pressure less than 90, or if the patient has features of heart failure or any cardiogenic shock. These four mainly are important. So syncope, hypertension, heart failure, and shock. These four mainly denote that the patient is hemodynamically unstable. We need to remember this because we will be discussing this later in the management part. So the patient just can be asymptomatic, it can be symptomatic, which mainly presents with palpitations, dyspnea, or fatigue, or the patient may just come with hemodynamically instability. And also this slide also discusses the complications. So what are the complications of atrial fibrillation? The patient just might come to us with the complication at the first presentation. That is unlikely, but it may happen. So the first complication of atrial fibrillation is thromboembolism. So the thromboembolism can lead to systemic thromboembolism and stroke. That means I will show in later slides that how the atrial fibrillation causes to form thrombus in mainly the left atrium or the left atrial appendage or even in the aorta. So this thrombus dislodges, and this causes an embolism in the cerebral vasculature, and this will lead to a case of CVD or cerebral vascular accident or a stroke. So the first complication is systemic, or even it can cause pulmonary thromboembolism. And the second complication is heart failure, because there is a lack of there is a abnormal atrial contraction, and there is usually if we fail to control the heart rate, this can lead to heart failure or left ventricular dysfunction. So these two are the main complications of atrial fibrillation. So we remember thromboembolism and heart failure. So the patient may come to us with these features as well. So when we ask the patient about the history, it can be asymptomatic, it can be symptomatic, or they can come with the complications. One is stroke, another is left ventricular heart failure. These two are the most common. Otherwise, what can happen? This can be vascular dementia because of As I said, there can be microembolism and hypoperfusion. They can lead to depression, impaired quality of life, and recurrent hospitalizations, and obviously death, right? It can obviously cause death. So as I said, these are the when the atria fails to beat correctly, there is a stasis of blood flow. And as we know from the Varco's trias, stasis leads to formation of thrombus. So this thrombus may form in the left atrium, this may form in the left atrial appendage, it can also form in the aorta. And this thrombus dislodges and causes the thromboembolism. So what are the examination findings? So pulse, we already mentioned a lot. This will be irregularly irregular. So irregular pulse can be divided into two parts. One is regularly irregular, another is irregularly irregular. In atrial fibrillation, this is irregularly irregular. The number one and the most common cause of irregularly irregular pulse is atrial fibrillation. We have to remember this for our whole lifetime. The blood pressure, it may be hypertensive because hypertension is a cause of atrial fibrillation. In the jugular venous pressure or the pulse, there may be absent A wave. So we know the jugular venous pulse has three waves, A, V, and C. The A wave, I always remember the A wave, the A for atrial systole. So as here the atria beats, atria cannot contract properly. The atrial systole doesn't occur properly. So there is absence of A wave. This is a very important finding as well. Even though we just see if the JVP is raised or not, we don't really see the waves, but we have to know theoretically what this is. The precordium, we see a specific thing. This is pulsus deficit. So what is pulsus deficit? Pulsus deficit is the as it says, the deficit. So that means there is a difference between the heart rate and the pulse rate when counted simultaneously. So we need two people. One would count the pulse, another would put the stethoscope over the precordium and count the heart rate. There is a deficit. So if it is more than 10 beats per minute, we can suspect that there is atrial fibrillation. On the precordium, we can also find that there is features of mitral valvular or any other cardiac disease. So mitral stenosis, we know that it causes a mid-diastolic murmur. We can find this. And we need to check for the thyroid status. That would include the hands, where we would find warm, sweaty hands, and fine tremor. We can also find the thyroid gland. It may be enlarged. And eye signs. Some eye signs are related to thyrotoxicosis. So we need to look for those as well. So these are the examination sequence that we would do if a patient of atrial fibrillation comes to us. So when we look at the pulse and see that there is an irregularly irregular pulse, these are the other things that we have to look for. And in cardiology, we always do the examination for these 4 parts. These are the main 4 parts for cardiology. And also we need to look for the complications and their features. So if the patient has already developed heart failure, we can look for the signs of heart failure. And if the patient has already developed a type of stroke, then we can look for the neurological examination and find the features. Okay, so investigations, this is from Davidson. So the assessment of patients with newly diagnosed atrial fibrillation, it should include a full history. We talked about how we take the history. Physical examination, we already talked about this. For the investigations, we need to do a 12-lead ECG. I will be talking more about this. An echocardiogram. Why do we need to do the echocardiogram? We need to see if there is underlying pathology can be diagnosed, such as the mitral valve disease or any congenital heart defects. Those can be visualized. Also, by an echocardiogram, we can see that if there is any formation of thrombus, this will also be visualized. And also, we need to do a thyroid function test to exclude thyrotoxicosis. So this is the most famous ECG of atrial fibrillation. So what is the features of atrial fibrillation? So the first one, we learned that this is irregularly irregular heartbeat, right? So the RR intervals, these are the RR intervals. These are irregular. Okay, so the RR intervals, these are irregular and they have no regular, these are not regular. So এখানে দেখেন 2 ঘর, এখানে আবার আড়াই ঘর, এখানে 2 ঘর, আবার এখানে আড়াই ঘর, এখানে 2 ঘর, আবার এরকম করে করে গেছে। হ্যাঁ, this is typical. And there is no p wave. There is no p wave. The absence of p wave. P wave denotes that the P wave denotes sinus rhythm. That means the impulse has been generated from the SA node. But in atrial fibrillation, we already mentioned that this is not generated from the SA node. So that's why there is absence of P wave. These two are the most important features of atrial fibrillation and ECG. One is P wave is absent and it may be replaced by fibrillatory F wave. I will show you to later. And then the RR interval is irregular. We need to count the rate, heart rate, because we classify atrial fibrillation according to ECG with atrial fibrillation with slow ventricular rate or atrial fibrillation with fast ventricular rate. So fast ventricular rate means when the heart rate is more than 100, as in here. So here the heart rate is around 150. So this is AF with fast ventricular rate. This is the picture from Davidson. This also is a picture for Davidson as well. So as you can see, the RR interval is irregular and there are no P waves in the A1. And the B1, as you can see, the same thing, the RR interval is irregular and there are no P waves. So, but what is the difference? This is the slow ventricular rate. As you can see, the heart rate here is around 300, 150, 100, around 60. And here the heart rate is around 100. So this is fast ventricular rate and this is slow ventricular rate. Yeah, 120 to 160, yes. Okay, so this is the fibrillatory F wave that I mentioned. This, see, the P wave is replaced by a fibrillatory F wave. So this we can also find, and as we can see the other features, there are no P waves and the RR interval is irregularly irregular. পরীক্ষা ইসিজি এরকম এএফ এর 50 এর একদম টিপিক্যালি দিবে একদম শুধু এরকম, আর পরবর্তীতে ইউজুয়ালি এএফ এর সাথে কোমরবিডিটিজ আরো কিছু ফিচার্স সহ দেয়। এটা সবসময় জানতে হবে, এটা আমরা শিখলাম। So what are the investigations according to the guidelines? So for all AF patients, we take the history, we do the ECG, we do the thyroid and the others tests, and now echocardiography. For selected patients, we can do an ambulatory ECG monitoring, transesophageal echo to see the status of the valvular heart disease and the left atrial thrombus. The CTNTHs, that means the highly specific troponin T, cardiac troponin T, or CRP or BNP or NT-proBNP to see the heart failure or cognitive function status. We can do the coronary CT angiogram or ischemia imaging, brain CT or MRI with patients with suspected stroke. And this is a special type of cardiac MRI we can do. And we plan a structured follow-up. So far we have discussed the types, the causes, the examination and the clinical features, the complications, and the investigations of atrial fibrillation. So now we move on to the management. I know this class is called 10 minutes with Davidson, but obviously it's not going to take 10 minutes, but I'm going to try and finish it within 30 to 40 minutes. That's why I might be rushing a bit. So the management. So the management depends on two things. Firstly, if there is a cause, there is an underlying cause that can be removed, or and the second is if it what type it is. So if we can find a clear precipitating factor such as the thyroid thyrotoxicosis, or it may be an acute chest infection, or it may be alcohol intake recent, we need to reverse the precipitating factor. And we need if it's not that case, then we need to find out what type it is, if it's paroxysmal or persistent, and then we treat according to three main objectives. One is the rate control, second is the sinus rhythm or restoration of the sinus rhythm, and the third is prevent recurrence of atrial fibrillation and reduce the risk of thromboembolism. So আমরা easily পড়ি rate control, rhythm control, and anticoagulation. So these are the main three objectives, and the fourth one, it can be a removal of any precipitating cause. So these are the main four headlines that we study the management of atrial fibrillation. So let's get into this. So this is from the guidelines. So we need to do an integrated AF management, which is patient-centered. So we need to do optimized stroke prevention, the symptom control or the rhythm control, management of cardiovascular risk factors and comorbidities. First, we start with the patient education and self-management, and we form our multidisciplinary team, and we do the lifestyle modification, that means removal of any cardiovascular risk factors, the smoking cessation, dietary intervention to lose weight, and exercise. And psychosocial management, as we saw, depression is a complication of atrial fibrillation, as the patient takes a lot of medications, and it causes a lot of stress and recent many hospitalizations. So we can offer stress management and any other psychological or psychosocial management as well, and strategies to promote medication adherence. And the multidisciplinary team approach, we need to do an MDT or a multidisciplinary team, which would include the cardiologist, the psychiatrist or psychologist, and the occupational health therapist, and neurologist if there is stroke, and other health physicians as well, other physicians as well. And we need to make a follow-up, a structured follow-up. So for paroxysmal atrial fibrillation, as we said, the paroxysmal, it's usually self-limiting. So, but it may progress to persistent or permanent. So if it's self-limiting and it's asymptomatic, then we can just it doesn't really require any treatment. We can just keep the patient on follow-up. If the symptoms are troublesome, we can use beta blockers. And these are the first-line therapy. So beta blockers is the first-line therapy. And beta blockers are particularly useful for treating patients of AF that have coronary heart disease or hypertension or heart failure, because we use beta blockers in these cases as well. Class 1C drugs, which is flecainide and propafenone, are also effective at preventing episodes. But for flecainide, we cannot use it if there is any structural heart disease or heart failure. Amiodarone is the most effective agent for preventing atrial fibrillation, but side effects, it has a long list of side effects. So that's why we restrict its use. So firstly, if the patient is symptomatic, we can just use beta blockers. This is the first line therapy. We just need to remember this. We cannot forget this. And also, if for rhythm control, we can use flecainide or propafenone or amiodarone for prevention. For intractable cases, that means if it cannot be managed by the medications, we can do catheter ablation. So catheter ablation means we will ablate the part of the atria that is producing the rhythm or the impulse. We would ablate it, and that would be solved by disconnecting the pulmonary veins from the left atrium electrically, and it will prevent the ectopic triggering of the atrial fibrillation. And this ablation usually prevents atrial fibrillation in 75% of the patients with prior drug-resistant episodes. But there are many complications of catheter ablation, as mentioned, that it can cause cardiac tamponade, stroke, phrenic nerve injury, and various others. So now let's come to persistent atrial fibrillation. So persistent or permanent, mainly persistent. So there are mainly two options for treating the persistent atrial fibrillation. Firstly, we try to restore to the sinus rhythm and maintain it. And the second, if we cannot do that, we just try to control the ventricular rate. So again, rhythm control and rate control. And we have to provide the prophylaxis against thromboembolism in all options. So how do we control the rhythm? An attempt to restore the sinus rhythm is particularly appropriate if the arrhythmia causes troublesome symptoms and if there is a modifiable or treatable underlying cause. So the restoration to sinus rhythm can be done by cardioversion. The cardioversion means restoration to sinus rhythm. It can be done two ways. One is electrical or DC cardioversion. That means by DC shock, or pharmacological cardioversion. So cardioversion can be done in two ways. And so this is a algorithm that will help us remember if we choose which cardioversion method we should choose. So if the patient has atrial fibrillation with poorly tolerated symptoms and a sinus rhythm is relevant target and cardioversion is considered. So first thing we see is patient is hemodynamically stable or not. As I mentioned in the clinical features, we need to know what is the signs of clinical instability. First is that there is a symptomatic hypotension. That means the systolic blood pressure is less than 90. If the patient comes with syncope or cardiogenic shock or features of heart failure, these four are the main symptoms of hemodynamic instability. So if the patient comes with this, we immediately go for DC shock. And this is true for all arrhythmias, not just atrial fibrillation. If the patient is hemodynamically unstable, we never go for pharmacological cardioversion, we go for DC cardioversion. So if the patient is hemodynamically unstable, we perform the electrical cardioversion. But here there is a matter of timing. If the atrial fibrillation onset is less than 48 hours, we give the patient heparin to anticoagulate. And if the patient comes after 48 hours, we do not know if the patient has already formed a left atrial thrombus. So if we give the shock in this case, we can dislodge the thrombus and cause a neurological event. That's why we have to do the echo first. Okay, so if they come less than 48 hours, we just anticoagulate and do the cardioversion. But after 2 days or 48 hours, we need to do the echocardiography first. If there is no hemodynamic instability, and again the same thing, if the patient has the atrial fibrillation onset less than 48 hours, we can give heparin and then go for the pharmacological cardioversion, or even consider the electrical cardioversion as well. But if the patient has come after 48 hours, we have to do the transesophageal echocardiography strategy. That means we do the TOE, and we can give the patient 3 weeks oral anticoagulant. In Davidson, it's mentioned 4 weeks, but yeah, we can give them 4 weeks oral anticoagulant, and then after that, we can go for the pharmacological cardioversion. So what are the options? What are the drug options for this? As I mentioned, that if there is any structural heart disease, we cannot give flecainide. But if there is, if the patient has no structural heart disease, our choice would be IV flecainide or propafenone. These two are mentioned in Davidson, so we just remember this. So if there is no structural heart disease, we can give flecainide or propafenone. But if there is presence of structural heart disease, we can give amiodarone. Flecainide is avoided because it can trigger atrial flutter. So this is the algorithm for rhythm control. So next is rate control. I can just remember the drugs of rate control by three letters. So I remember A, B, C, D. So A for atrial fibrillation, B for beta blocker, C for calcium channel blocker, and D for digoxin. And this is actually the serial we maintain. For atrial fibrillation, as we already studied, the beta blocker is the first line therapy. And the next thing we use is the calcium channel blocker, which are the rate limiting calcium channel blockers. That means verapamil or diltiazem. And the last one is digoxin. So the beta blockers and the rate limiting calcium antagonists are more effective than digoxin. So that's why I said this is actually the serial B, C, and D at controlling the heart rate during exercise and have additional benefits in patients with hypertension or structural heart disease. One thing is we give digoxin in AF patients if the patient has heart failure, or if the patient is already taking digoxin for heart failure. Combination therapy with digoxin and a beta blocker can help with rate control, but calcium channel antagonists or calcium channel blockers should not be used with beta blockers. We know that CCB and beta blocker both cause bradycardia, so we cannot give them together. So now let's come to thromboprophylaxis. So why is there thrombus formation? As I already said, that there is loss of atrial contraction and left atrial dilates and causes stasis of blood in the left atrium and may cause thrombus formation in the left atrial appendage. And this predisposes patients to stroke and other forms of systemic embolism. So how do we assess if the patient has the risk of stroke? So there are two scores. So the first, the risk of stroke is usually assessed by the Chadva score. Okay, so the Chadva score, the A2 and S2 Chadva score, and there is After anticoagulation, there is always a chance of bleeding. So we can assess the bleeding risk by the Has blood score. I'll be talking about these two in a bit. So if the Has blood score is 3, so we need to do very careful monitoring and when we provide the patient with anticoagulants. So let's first discuss the Chadba scoring. So as we can see, the first thing that is written, that the stroke risk scoring system for non-valvular atrial fibrillation. That means, why is it non-valvular? Because the valvular atrial fibrillation, or the ones that is associated with mitral stenosis, this has already established risk factor for thromboembolism. In these patients, we give it anticoagulation. That means mitral stenosis patient with atrial fibrillation, anticoagulation দিতেই হবে। কিন্তু যখন আমরা জানি যে নন ভালভুলার, সেই ক্ষেত্রে we can do this scoring. So what for C? C for congestive heart failure, H for hypertension. This is the A2, age 75, and there's another A, that means the age is 65 to 74. D for diabetes, S for stroke, that means previous stroke or TIA, V for vascular disease, and SC, that means sex category. So this one is the stroke has 2 points, but sex category female, that means 1 point. As we already said in the first beginning slides, that the males are at more risk of atrial fibrillation. So the maximum point is 9. If the patient has 0 points, we don't need to do any prophylaxis. If the patient has 1 point, we can do the anticoagulation. And if the patient has 2 or more points, the anticoagulation is recommended. I'll show an algorithm in a bit. So the Has blood score, I'm not going to go into this. You can just remember this, that what are the bleeding risk scoring system for the patient receiving the oral anticoagulation. Okay, so this is the algorithm that I was talking about. So as I said, any patient with atrial fibrillation and it's eligible for the oral anticoagulation, that means there are no other contraindications. If the patient has prosthetic heart valves or mitral valve disease, in these patients, we immediately go for the vitamin K antagonist, that means warfarin. And the INR target, there is an INR target. In cases of prosthesis, it depends. And for mitral stenosis, it's usually 2.5 to 3.5. But in as a whole, we can remember that the INR target for oral anticoagulation is 2 to 3. So as we said, this part is warfarin. So if the patient doesn't have this, we do the scoring, the non-valvular stroke risk estimation scoring. This is the Chadba scoring. So if the patient is 0, as we said already, right, the 0. And for females, as we can see, the being female, you get 1 point. So that means, it doesn't mean that there is any risk. So if female, it's 1, and for males, it's 0. So if it's that, then we don't need to go for any antithrombotic. And if the scoring, it's 1 or 2, then we can consider the anticoagulants. And if 2 or 3, it's highly recommended. So now let's talk about how we can anticoagulate these patients. So the patients with mitral stenosis or prosthetic valves, we go for vitamin K antagonist or warfarin. But here we have 2 options. One is the vitamin K antagonist, another is the DOAC or NOAC. DOAC means directly acting oral anticoagulants, or the N for novel. These are the same thing. We can give the NOAC or the DOACs. So warfarin. Warfarin therapy is adjusted to a target INR. Okay, by the way, this is taken from the ESC guideline. So warfarin therapy is adjusted to a target INR of 2 to 3, and it reduces the risk of stroke by about 2/3 at the cost of an annual risk of bleeding of 1 to 1.5%. So as we already know, the 2 or more, we give the warfarin. But there are many complications and contraindications. These include the peptic ulcer, uncontrolled hypertension, alcohol misuse, frequent falls, and poor adherence, and also poor monitoring. We need to always monitor the INR if we give warfarin, and the use of other drugs that might interact with warfarin. If bleeding does occur, we have an antidote that can be reversed by administering vitamin K or other clotting factors. So now the DOACs or NOACs. So the factor 10A inhibitors, we need to know this. This comes in the exam. So these 3 drugs are the 10A inhibitors: the rivaroxaban, apixaban, and endoxaban. And there's another one that is the direct thrombin inhibitor, that is called dabigatran. So these are collectively called directly acting oral anticoagulants or DOACs. These can be used as an alternative. They are at least as effective. That means that they are similarly effective as warfarin, but they are associated with a lower risk of intracranial hemorrhage. What are the other advantages? That means that there is a lack of requirement for monitoring and the fact that they have fewer drug interactions. And they also have a reversal agent. So for dabigatran, the reversal agent is named idarosizumab. It's an antibody. When the drug name ends with MAB, it's usually an antibody, monoclonal antibody. So idarosizumab is the reversal agent for dabigatran. So this also allows the acute bleeding complications to be managed more effectively. So for the management, let's review in a bit. So the management, as we said, there are mainly 4 points: rate control, rhythm control, anticoagulation, and the fourth one is any removal of the precipitating cause. So we need to form a multidisciplinary team. For paroxysmal atrial fibrillation, in asymptomatic cases, we do not need to do anything. But if the symptoms are troubling, we can use beta blockers as a first-line therapy. For persistent atrial fibrillation, for rhythm control, if patient is hemodynamically unstable, we go for DC shock. If the patient is hemodynamically stable, we can also consider DC shock, but for pharmacological cardioversion, if there is no structural heart disease, we go for flecainide or propafenone. And if there is structural heart disease, we can go for amiodarone. For rate control, we can use 3 types of drugs: beta blocker, calcium channel blocker, which includes verapamil and diltiazem, and digoxin. For thromboprophylaxis, we need to, for mitral valve disease or prosthetic valves, we immediately go for thromboprophylaxis with warfarin. But in cases non-valvular atrial fibrillation, we do the scoring, which is the Chadbus scoring. And if the patient is scored 1 for male or more than 2, more or equal to for female, we go for the anticoagulant. There are 2 options. One is warfarin, another is the DOACs. DOACs are now considered first-line therapy, as it's written here in the ESC guidelines. So NOACs are generally recommended as first-line therapy. We also use this practically as well. So what are the DOACs? The 10A inhibitors are rivaroxaban, apixaban, and edoxaban, and the direct thrombin inhibitors are dabigatran. So this is all about atrial fibrillation, from starting from the definition to ekdom shesh porjonto shobi discussion hoise. So it's been a lot more than 10 minutes with Davidson, but I hope that this has been helpful for everyone. So if there are any questions, and if anyone is connected here with Zoom, you can ask me. Okay, so there isn't, if there isn't any question, I'm going to end the session. I hope this has been helpful, and I hope that you guys like this session, and you guys can join Genesis for other exciting Davidson sessions and also the batches as well. Thank you so much. Assalamu alaikum.